כמה מילים בעברית לפני זה. המפגש האחרון של בית הספר לאנדוקרינולוגיה שהיה כל השנה, אז אני מנצל את ההזדמנות הזאת להודות באמת לכל החברים שחלקם פה, שבאמת תורמים מזמנם ללא כל תמורה, וזה הרבה עבודה לארגן כל יום עיון ולשבת ולהחליט מה. אז דוקטור גליה אורון, דוקטור אסף בן מאיר, פרופסור אריאל הורוביץ, דוקטור אבי הרלב, אני, דוקטור טולדנו שהוא אנדוקרינולוג, דוקטור טל לימבק, דוקטור צוקרמן שגם היא אנדוקרינולוגית, פרופסור שחר קול ודוקטור עדי רכש שהצטרפה השנה לגנטיקה. אנחנו כמובן עובדים תחת המטריה של איילה ועם טליה שעוזרת לנו גם כן והייתה היושב ראש הראשון של הבית ספר. שנה הבאה בית הספר ישנה קצת את פניו מכיוון שראינו שאין הרבה מתמחים, שזה היה המטרה שמתעניינים בפוריות ורוצים, אז שנה הבאה נשנה את המתכונת לימי עיון שהיו קודם, שיהיו יותר על דיבייטים ועל דברים יותר חדשניים, והמטרה היא להביא חזרה לא רק לימים כאלה את חברי איילה, כדי ליצור באמת בדברים שמה שנקרא אפדייטינג, ליצור דו-שיח ועדכונים, וזה אז כולם מוזמנים, זה יהיה פה באותו מקום, כי המיקום פה הוא מצוין גם מבחינת ההגעה לכולם, וזה יהיה ללא תשלום, לא שה300 שקל מנעו מאנשים לבוא, אבל זה יהיה ללא תשלום ומותנה בחברות באיילה ובאיגוד למיילדות גינקולוגיה או באיגוד האנדוקרינולוגי, וכולם באמת מוזמנים. זה המפגש הראשון יהיה ב-14 לספטמבר, הוא יהיה על PCO, אז אתם כבר יכולים לסמן ביומנים מי שרוצה. אני אזמין את טליה רק שביקשה לומר כמה מילים, ואז נתחיל בפאנל שנועד בעצם לסכם את כל הדאטה שעשינו לחיים היומיומיים הקליניים.
בעיקר בשביל להגיד תודה, כי האנשים שבהנהלת בית הספר, זה עדיין שומר על בית ספר, עשו עבודה יוצאת מן הכלל השנה. אנחנו מסיימים עכשיו שנה שלישית של בית הספר וזה באמת המון נחת. עכשיו מה שבאמת יקרה בשנה הבאה, אנחנו שומרים על המותג, נוצר מותג בית הספר לאנדוקרינולוגיה וגנטיקה של הרבייה, אבל הוא יהיה פתוח לכל חברי איילה, כמו שאמיר אמר. לגבי בתקווה שבאמת תהיה בסופו של דבר הכרה בהשתלמות עמיתים, עדיין יש כאן רישום של המשתתפים לטובת אלה שירצו לקבל תעודה על ההשתתפות שלהם גם השנה וגם בשנה הבאה, ואני מקווה מאוד לראות את כולם בשנה הבאה. נכון שהתוכנית כבר סגורה פחות או יותר מבחינת נושאים, אבל מי שיש לו משהו טוב להציע, משהו חדשני להציע, אנחנו מאוד פתוחים, מאוד נשמח גם לשיתופי פעולה, גם להצעה של דברים חדשים, ובטוחים שהשנה הרביעית תהיה עוד יותר טובה אולי מקודמותיה. ושוב תודה לאמיר במיוחד שמנהל את בית הספר, מרכז אותו ועושה יופי של עבודה. תהנו.
Okay, for the panel I would like to ask Peter, Shachar, Schulman and Dovieto. We will present 3 cases and you can share your experience and your data. So the first case is a very simple and routine case, 32 years old patient, unexplained infertility, underwent IVF treatment, fresh cycle, 12 oocytes were retrieved, triggered by Ovitrel, luteal support with endometrine 3 times a day, and she called you, she is complaining vaginal bleeding 7 days after ovum pickup. And the question is, what is your recommendation? Is to evaluate her progesterone level, to change the luteal phase support, to increase the doses, to change or to add something. So who would like to start?
Usually what we are practically doing is trying to continue with the vaginal progesterone and adding IM progesterone to the luteal support. And it depends on the severest of the vaginal bleeding. If she's bleeding a lot, so we are switching to IM progesterone completely.
IM only or
IM only, if she is bleeding a lot. If it's only spotting, so we are continuing with the vaginal and adding IM progesterone every alternate day.
we need to think why she bleeds. So she might bleeding because the HCG trigger caused excessive, as we said, progesterone production during the early luteal phase, which decreased. Now we have to understand that some patients, when the endometrium is facing a decreasing progesterone level, although the level itself might be good, the trigger for bleeding is a decreasing trend in the hormone, not the level itself, which happens a lot in our field of reproductive endocrinology. Many times the kinetics of the hormones is what is important and not the level itself. To give you an example, we all know that the kinetics of increasing HCG after implantation is extremely important to rescue the corpus luteum in the natural cycle. If the way the HCG increases is not doubling every 48 hours, we have bleeding many times. The same with estradiol during the follicular phase. We know that if the estradiol level increases very rapidly, we are facing a problem of HSS risk. So this is the same mechanism that happens in the natural cycle with those patients who are coming to you spotting, complaining of spotting in the late luteal phase. You check their progesterone, it could be 17, 20 nanomole per liter, but they have spotting. Why? Because the trend of the decreasing progesterone from the peak mid-luteal phase into the late luteal phase is by the endometrium exposure to this decreasing level is the cue for a bleed. So this again could happen with this patient. Of course, once she bleeds 7 days after retrieval or transfer, the chance for successful implantation is not so good. I agree that the only thing you can do at this time point is to supplement with more progesterone, but then again the chances are not so good. But you have to learn this patient for the next cycle. If she doesn't conceive and you're going to plan the next one, make sure that the highest progesterone level will coincide with the implantation period, not in the early luteal phase, but in the mid-luteal phase, again to maximize endometrial activity, receptivity for this specific patient.
Yeah, I understand that she's not pregnant now.
7 days after OPU, so you can...
Okay, so it means it's a little bit too late to rescue, I think. So I think you should think about the next time. The next time, I think you should change maybe the induction protocol, and then maybe you can use a better luteal phase support, like in the old time, with some HCG, as they suggested in the two lectures previous. So it means, I think that the endometrine, as a supplement, a local supplement, maybe is not enough. So I think that then HCG, like Pregnil or Ovitrel, if she not at risk of OHSS, it would be the best management of this case, or cases like this. Or if you, as an alternative, to give intramuscular, because we know that the vaginal progesterone is also weaker, but many times, they don't use it adequately. So next time you should challenge with some intramuscular progesterone. Or as I heard from Peter, that they use intrarectal, which maybe is a better absorption than the vaginal route.
7 days after OPU, you think it's too late to say this?
I think that it's two days after implantation. And I think, on my opinion...
He's got the results there.
No. Yeah?
No.
Maybe, no. Okay.
So I'd just like to comment, because I actually agree with all of you, but I'd like to give you one interesting case, and this could be one of these ladies. So for my PhD student, and Shahar showed her results, we're going to publish a paper in Human Reproduction now, and she's going to defend her thesis, which is the role of mid-luteal progesterone in terms of reproductive outcomes of HCG-triggered cycles and agonist-triggered cycles. So for 2 of these patients, we used 10,000 units of HCG for trigger. These 2 ladies had 10 follicles. We retrieved 8 to 10 metaphase 2 oocytes. But during mid-luteal phase, there was a complete flat curve. So they were supported. It's an HCG trigger. They had a standard vaginal luteal phase support. There was no action whatsoever from these corpora lutea. The only thing she had in circulation was this 30 nanomolar, which derived from the vaginal. And as you know, in a stimulated cycle, we need to be significantly higher, above 100. So telling us that a corpus luteum is not a corpus luteum, they are individual. They will, some of our patients, few of them, but I think we all had these patients who never succeeded in fresh cycle. They always conceived in frozen cycle. And in those days, we actually didn't have an explanation. But for me, this was an eye-opener, that you cannot rely on the endogenous production from a corpus luteum in all our patients, despite you kick them very hard with HCG. So you were saying, okay, what can we do now for this specific case? Well, obviously, I would try to rescue, because sometimes the vaginal bleeding is more like a cervical bleeding than it's an endometrial bleeding, and we don't have any other choices. So I would definitely also add the IM progesterone, because I would probably be more reluctant giving her HCG, because this could be the patient whose corpora lutea don't function. So I would go more for the IM progesterone for this case now. And then the next time, I would measure progesterone in this lady around day 4. So what we saw during our measurements is there is a very high degree of circadian variation in progesterone around mid-luteal phase. But during early luteal phase, it's more stable. So if you measure on day 4, after oocyte retrieval, it will give you an impression whether you are very low or very high. So in the very low patients, like this one, let's say she was very low, I would, for the next cycle, I would measure day 4. If she's low, I would then boost with progesterone probably, rather than HCG. Okay. So what happened to this lady?
No, she didn't get pregnant, but I would like to ask you, we do like Raul, but all of you are aware to the study about the Dufaston. There is, what do you think, Peter, or the other, about your experience about the Dufaston instead of iron progesterone, that it's very uncomfortable for the patient. So this is a good choice for the patient who are with low progesterone day 4, like you said, or bleeding?
So when I travel quite a lot in China, and our Chinese colleagues use it, but they don't use it as the only. They use it as a supplement. So they use vaginal and oral in combination, and seem to be quite happy about this. So, well, no, they don't. No, they don't. So they tend to use it like this.
Professor Carr, yes.
Can I make a comment?
Amir, before you showed this slide, I was going to suggest, but didn't have the opportunity, that with vaginal progesterone, certainly not quinone, but endometrium and utrogestan, there is a lot of discharge. It is often washed out. You said, Peter, that they might not use it properly, but not only do they not use it properly, it may also all be. Once there's bleeding, even more of it is washed out. And then, rather than the painful intramuscular injections, maybe oral dydrogesterone would be the answer instead of that. Now, what you said is that they use it as a supplement to other progesterone in China is true, but I think that was probably before the Lotus study came out. Now that the Lotus study has come out comparing vaginal, they compared utrogestan, okay, showing a slightly superior effect. The problem is that this was a non-inferiority study, and I personally have lots of problems with non-inferiority studies, but on that, it is not inferior. In fact, I have done a meta-analysis putting this together with Amit Patka's work and a number of others, in which case you find that the dydrogesterone is actually superior statistically significantly. And I think when Lotus 2 comes out, which is going to compare dydrogesterone to quinone, and I do actually know the results, that it's slightly better again, we might just get statistical significance from this study and the next one which is being performed. So I think dydrogesterone might be an alternative. Yes.
So the next will be Lotus 3 comparing dydrogesterone to IM.
Well, I don't know that that's planned. It would be very valuable.
Yeah, it would be, definitely.
I have a question. Why actually to support with progesterone? We heard all this excellent speech before, but what are the evidence that we need progesterone for luteal support in fresh cycles?
In fresh cycle.
What was missing in the dihydroprogesterone study is another arm of placebo.
Yeah, okay.
And
yeah.
I'm not sure that if
Yeah.
you are not supporting, you will get also the 30% pregnancy rate.
I think there are some data, good data, I think from the Spanish group, and we also used years ago that we supplement with progesterone only the first 6 days, and then we stopped. And I think there are some data from EV showing the same thing, starting the day of HCG and continuing for 6 days and then stop it. And they didn't find any difference, because what you need is just to reach the high levels during the period until the progesterone will increase. Yeah.
But
and
you
then
know,
we
you know,
rescue.
there is a Cochrane review or meta-analysis looking at luteal support in fresh and frozen thawed embryo transfer. And actually, there are I think that one study, RCT, that compared HCG to placebo for luteal support, and 3 studies that compared progesterone to placebo in fresh cycles. And no one looked at live births, only ongoing pregnancy rate. And I think that the evidence at the end of the day is there is no significant difference between placebo and any kind of support during the fresh cycle. I'm speaking about fresh cycle.
Yeah.
So
But Raul, so if
we are all adding progesterone because we
yeah, we
grew up on this.
But again, I think for Shahar showed very elegantly that the pulsatility of LH varies from patient to patient. And if you are a patient with a high pulsatility after the trigger, you will do excellently well. But if you are a patient who didn't even respond to the trigger, the HCG trigger, then obviously you have no function whatsoever and you will need it. So how many are these patients? Well, they were 2 out
The
of...
question is you will need it. If these are not the patients that are deemed to fail, and you never matter what you will do, at the end of the day they will fail. And only the one with the persistent pulsatility will succeed.
Well, I don't know,
To
but...
randomize these patients that don't have pulsatility to either progesterone
Yeah,
or not.
that's true.
And that will give the answer, because otherwise, because if you will support this patient, the result will be failure, so why to give progesterone?
What was special in the Spanish group is they used only IM progesterone for the 6 days.
Okay, so unfortunately the patient did not get pregnant, and the practice question, she's coming to you, and in one sentence or few sentences, if you can say what is your recommendation for luteal support for her next cycle?
So if she will not be at risk to develop OHSS, I will probably aid HCG during the embryo transfer,
And if she's at risk?
and I will double the progesterone vaginal dose, and might add IM progesterone every alternate day.
What
Alternate
increase?
day.
More than 300 milligram of endometrine, or 2 times Crinon? Or?
2 times Crinon.
Okay.
Or 200 twice a day of endometrine, or 300 milligram 3 times a day of utrogestan.
Probably I will repeat the same stimulation during the follicular phase, because she had how many? 10, 12? 12 eggs. And then trigger with the agonist and give 1,500 units of HCG 2 days later after the retrieval. And if we can follow, skip some unnecessary follicular phase blood test and look at the progesterone in the mid-luteal phase to verify that it is high enough. I predict it to be around the 300 nanomole per liter range, which will mean that indeed we support the endometrium as needed, and not further support is necessary. If she becomes pregnant, that's fine. Again, the HCG will come from the newly implanted embryo. If not, she might again bleed, not 14 days after oocyte retrieval. Many times they say, wow, I bled too early, maybe because the support is not good enough. The answer is, of course, not the support was good, but the pregnancy did not occur. So we can delude ourselves and give progesterone for 2 weeks or 3 weeks or a month, and you will not bleed, but this will not produce any pregnancy.
Okay, already they said that HCG, just modifies the stimulation protocol. And if you repeat once again, then think about freeze all and replace in a natural cycle.
So I agree with Shahar. I would also go for agonist trigger because was an OHSS risk patient. I would add the either 1,000 or 1,500 bolus according to the response. I would measure progesterone, and if I needed more, I would then do what we do, the 2+2, actually quite a lot. So it's 2 vaginal, 2 rectal, which patients cope with very well if the progesterone is very low, to avoid the IM progesterone injections. But in certain cases, I would use not 2+2, but just IM.
And you think the best time to check progesterone is 4 days after OPU?
It looks as if, you'll see the paper hopefully within the next 3 months, it looks as if we want to measure without too much fluctuations in progesterone, it's during early luteal phase during the rise of the curve, and this will already give you a clue whether this is low or high.
And if this patient has a frozen embryo, what do you think the best protocol for a frozen embryo transfer? You would change the policy, or you choose the same if she's bleeding, or it doesn't matter for you?
No, I think, this is discussion, and Raul was talking about the meta-analysis showing that whatever you do for frozen embryo transfer, there's no difference. But what we saw, we did an analysis of 3,500 Scandinavian frozen embryo transfer cycles looking into the same issue. So if we go for live birth rate, the bottom line, there's no difference. But if we go for pregnancy loss, we can see that we lose significantly more pregnancies in the HRT fed cycle. Probably because we were just relying, as I showed you, that one size fits all our patients. So, alluding to our data, we will start monitoring our luteal phase of the HRT fed cycle, and we will follow progesterone levels because you reach the plateau after approximately 2 days already. So at 2 days with progesterone in the HRT fed cycle, you will know where you want to be, and we want to be above 11, probably closer to 50, 60 nanomolar, and then we will add the extra progesterone that we need.
Spot. And you saw we were trying the concept as a modification in our protocol, and we can see definitely that we have a rise just by one injection. So obviously, the thing is now these patients are probably very few, those patients with very poorly functioning corpora lutea. But maybe in your database, you would probably also see differences in response in progesterone levels because you also treat your patients with the same, one puff in the morning, one puff in the evening. And it would be interesting to see what is actually the range of progesterone, because this would tell you, okay, one thing is the resorption, the nasal resorption, but the other thing is definitely the quality of these corpora lutea. And you will probably see that there is a huge variation from patient to patient how their corpora lutea will react to the same regimen. Yeah.
Yeah, but what? How do you add? This is vaginal, IM, whatever.
Where do you stop the Farrelling? Exactly. You can even go earlier than that. That's exactly.
I remember the paper that you wrote, the big analysis, and you came up with a very nice paragraph on the use of agonists during early implantation, because I think this is what has been keeping some of our colleagues away from using the agonist, these early reports, and also some papers by Roy Homburg saying that, well, we should not use agonists during implantation, etc. But you gave a very elegant message there, also stating that, well, if you use long agonist protocol, which is still the preferred protocol in 70% of cycles all over the world, you would have agonists there for several days around implantation. So this is definite, but I think this is what scared quite a lot of people. But you know, so you could say you could probably make your protocol even more elegant by, as you were saying, stopping earlier.
Sure. He said 10 days. I think you can stop 8 days.
What not to give the analog only during the peri-implantation window? That's what he said. For 3 days. That's what he said. That's what we're doing. We are giving it 7 days after. Our protocol, actually, for frozen towed embryo transfer, we are using the natural cycle protocol, looking at LH for ovulation, and then supporting the patient with progesterone, adding HCG on the day of transfer to activate the corpus luteum. Again, all these cytokines that you spoke about. And 4 days later, we are adding decapeptyl, actually, Tezaric protocol.
Yeah. So this is fresh cycle.
We doubled our ongoing pregnancy rate in our center. Frozen cycle. Speaking about frozen cycle. Yeah, we doubled our pregnancy rate by adding these 2 injections of HCG during the transfer and decapeptyl 4 days later.
Yeah, because Itzkovich was telling me in the coffee break, and you know, I had this. We discussed this previously. Okay, we're back to future, because now you want to bring HCG in again, but the difference is we are triggering with agonists, we're not triggering with HCG, so there is a huge difference, but HCG definitely belongs to luteal phase, and I'm sure it's, yeah.
Okay.
So the only thing you need is, because this is like a nice, large, multicentric trial, an RCT to convince the international society. That's it?
Do you think the next step will be to come back to the GnRH pump? Why not? It's much more physiologic. For the patient, not, but no stimulation, only for the luteal phase. for 1 week. But is why? Why? It's a subcutaneous one. You change every 2 days for 6 days, 7 days, 3 times you should change. You'll give it appropriately during the luteal phase instead of giving decapeptyl or whatever, as a luteal phase.
Problems are going to bed. I wonder if. One thing that I wonder is, Itai, you're adding the Cinarel twice a day, aiming to increase the LH. You're adding nafarelin twice a day for luteal support, aiming to increase LH to support the corpus luteum. Right? Okay. Why not to add the real LH? Give Luberis twice a day. Why Cinarel? I'm not sure that with subcutaneous Luberis you will get abscess or whatever. So they will reduce the price. But if the concept is increasing LH, so probably you have to give LH, because what I'm scared of, giving the Cinarel mid-luteal for 14 days, that we know that after 7 or 8 days will be downregulation of the hypophysis and luteolysis.
No,
Only if she's pregnant, but if she's not pregnant, that's what will happen. So okay, give nothing again. So give nothing and wait to the pregnancy if she will be pregnant. So we can give Luberis all over the luteal phase and decapeptyl during the mid-luteal.
Well, listen. This is not a bad idea. You could, yeah, of course. Well, it's your probably also, but it's also my idea. No, I just wanted to say, as regards the LH, you referenced the Papanikolaou paper. Okay, we did something else. We did an agonist trigger for 20 patients and we used daily 300 units of recombinant LH. It's expensive. So our progesterone levels, mid-luteal progesterone levels, were 300 nanomolar with 300 units of LH daily. And again, it's a pilot study, elegant pregnancy results. So obviously you can do it. The problem is the injections, but mainly the price.
Okay, any other comments? The next case is, we are all aware for all, but just to summarize the case, there is a high-response patient, PCOS, undergoing IVF, triggered by GnRH agonist, and she wants, and the physician wants, fresh embryo transfer. So just, I would like to hear all of you, what is your limit for HCG triggering, and the E2 level, number of small follicles, number of big follicles, and what is the recommendation for luteal phase support?
2,500 picogram, which are equivalent to 9,200 picomole, and more than 18 medium size and larger oocytes, follicles.
How many?
More than 18.
More than 18 without without connection to the E2?
Without connection to the E2. And this is for the trigger, and then if we get more than 20 oocytes, we freeze all.
E2 might be very misleading because it depends on the type of gonadotropin you use in the follicular phase, whether it has LH or not. Also, it depends on the degree of response of the pituitary gland to the antagonist, if you use antagonists. Because if a patient will drop the endogenous LH significantly post the antagonist during the follicular phase, the estradiol level will be a plateau or even decrease. However, the follicles will continue to grow. So E2 might be extremely misleading. Number of growing oocytes is a good number. We heard 18, some people say 15. However, I think we should take into account other things. As Peter said, it's not one size fits all. So for giving patient 15 might be too high. If she is thin, if she is young, if she has a previous history of exposure to OHSS, she should be treated differently, very cautiously. So again, when you make the decision, you need to take into consideration a whole list of factors, and then you make the decision. But always, if you are in doubt, freeze all, don't risk it. Because
What is your cutoff? Number of oocyte?
usually 15, but then again, I tell you, there are 15. But there are patients that will give only 12 because some of the follicles will be empty. It happens. Or if they are too young and thin, so I will not do the transfer fresh. I will freeze off. So we need to look at the whole picture, not.
So your limit is the number of follicles or the number of oocytes that you retrieved?
No, it should be the follicles because, some.
No, but after
Yeah.
you triggered with GnRH agonist. But
So you look at the ovary when you do the oocyte pickup. And if you count more than 20, or you need to be cautious, even though you get, say, 10 oocytes. It happens. So if you said only oocytes, then you might lose on some cases where you have too many follicles that are empty and will not produce the oocytes.
So you look on the ovary during the
Exactly.
pickup
So again, to give you a very simple recipe will be superficial.
and
need
if
to
you
look at-
decide to do fresh embryo transfer, what do you do?
On this patient?
Yeah.
I will not do it.
First, I agree that PCO patients are not very problematic. But as you know, if you give a GnRH analog, you know me, I'll never add nowadays, with the latest experience that I have, I will not add any HCG because you have very bad experience with very, very hard OHSS cases. So I think that if you give a GnRH analog, freeze all. If you give HCG, then just add some progesterone, luteal progesterone. I don't think that you have a limit because the E2 can't be a limit because there is never a good correlation between the E2 levels in PCO patient and the true what's happening in the ovary. You can have maybe 10 or 15 eggs with a lot of small follicles which will give you the true OHSS later on. So I think that you should decide from the very beginning if you will replace based on progesterone, and it doesn't matter how many, for sure not over 20 eggs, but that you will have 10 eggs, is that you will not be reassured that there will not be OHSS.
So I think this is now individualized luteal phase support, so we have to individualize, and this is actually what we're doing in our unit. As for the HCG trigger, we abandon HCG trigger for all patients. So we just use HCG in long agonist, which is like 15% of our patients. All the others receive an agonist trigger, and I agree with the others. Estradiol is not predictive of anything. The only thing which predicts is the number of follicles that you retrieve. Now, for HCG trigger, those of you who did this, there's a very nice review by Griesinger in which they were stating that the cutoff level for OHSS, moderate and severe, is more than 18 follicles on the day of trigger above 11 millimeters. This is for HCG trigger. This is what they saw in all these analysis from the Elonva trials, more than 18 follicles above 11 millimeters, so not just mature follicles. These smaller follicles will obviously also participate in the OHSS condition. In my unit, we made it slightly, we need to think a little bit more. So, because all patients are agonist triggered, and the clinician who does the pickup will make an estimate of how many follicles on each side before the pickup above 12 millimeters. And then we individualize the luteal phase support. Again, they are all agonist triggered. So up to 10 follicles, we add 1,500, and then we add another 1,500 5 days later after the pickup. For those between 11 and 15, we are now approaching although you cannot compare agonist trigger to HCG trigger because we just rescue smaller parts, smaller amounts of the corpus luteum in an HCG triggered cycle, you will rescue much more, and this is why the cutoff for, let's say, freeze-all for HCG is significantly lower than that for agonist. So over the years, we randomized nearly 1,000 patients, and we kept an upper limit for freeze-all in agonist-triggered cycles at 25 follicles. 25 follicles. And doing so, we, in our high-risk patients, we did not have any OHSS with 25 follicles as a cutoff. So I just want to go back. So again, it's like individualization up to 10, 11 to 15, and then the group of patients with 15 to 24 follicles that we want to do a fresh transfer, we just give 1,500. So in general, you could say all patients will receive 1,500, but the fewer the number of follicles, obviously the lower the progesterone, the more we want to boost. And for these patients, we add either 1,500, if very few follicles, or 500 up to 14 follicles. That's the individualization in our unit.
Okay, one of the privilege of the organizer is to does promotion to his study. So we are doing study at Mayo with Professor Schulman and Tal Shavitza are here. And we are doing the cutoff, is like Raul said, the E2, although it's not a good sign. E2 above 2,500, we give decapeptyl 0.2 milligram. And the day of OPU, if there is a E2 level above 400, 5,000, there is exclusion criteria to fresh embryo transfer or more than 20 outside. And then, like Bar Chava, similar to his study, we give repeated dose of GnRH agonist, decapeptyl 0.1 from day 3 every other day till the day, actually it's 5 shots, till day 12. And it goes very slowly. We did 33 patients, and you see, we took estradiol. So you see the estradiol is, this is day 3, day 6, and it's decreased here. Progesterone, you see it's increased, it's a nanogram. So it's increased after the repeated dose from day 3 on day 5, and day 6 and day 9. And this is the LH. Also increased after the repeated dose of decapeptyl. And we did 33 patients with 45.4 clinical pregnancy and no OHSS. So we think, like you, this is could be good solution for luteal phase support in limited cases that you want to do fresh and you are not at high risk for OHSS. We started with an arm of it was 85 of HCG, and we had 2 cases of severe OHSS, so we stopped this arm and we are continuing only with the GnRH agonist repeated dose arm, and that's our... and one of the bias that we give vaginal progesterone, we thought to do it without vaginal progesterone, only GnRH agonist, but we didn't do it yet because maybe we will change it now with this result. But the bias that we give progesterone, vaginal progesterone.
So you don't have a comparator in this study? This is just one arm study?
Yeah, one arm to proof of concept.
Yeah, because I was just thinking, in order to avoid Raul's constant discussions for the comparator, you could put in, when you're going to do the big study, you could put in a vaginal progesterone support arm and see that there's, which we probably all know, that there's no difference. But then you would kill questions like this.
Okay. Yes.
I feel that the bromocriptine decrease the pregnancy rate, but they don't have hard data, but no personal data. I feel that there's less pregnancies with bromocriptine. I don't know why. Not bromocriptine, actually carbagolin. Actually carbagolin, not what we give is carbagolin. But I don't know.
We are adding bromocriptine only in patient after HCG trigger that we are freezing all. This is the only case. We're not, if we are adding bromocriptine, is to avoid or to try to reduce OHSS risk. And in these cases, we're actually giving, we are not transferring in these cases. Always. No transfer. Some of our patients are getting HCG trigger, and we see that there are many oocytes, so we freeze all and add the Dostinex.
But you give Dostinex only after GnRH agonist?
If we can predict the risk on the day of HCG trigger, so we start on HCG trigger, but not after GnRH agonist. Always after HCG, but no later than the day of OPU. Usually on the day of HCG or maximum the day of OPU.
According to the meta-analysis, Dostinex does not prevent the severe HSS. This has been well established. So I think I also do what Raul says. If you're stuck with the patients on the long agonist protocol, which you cannot trigger with the agonist, of course, and you trigger with the HCG, and it's high risk for episode freeze all, you give Dostinex for a few days and hope for the best.
But actually, this is not completely true, because you can change your long agonist into an antagonist. This is Martinez from Dexeus in Barcelona. She published 2 papers on this, pilot papers, in which papers... Okay, you rejected them, but still, they used the protocol. And the interesting thing was that if you shift to the antagonist during a long agonist, and you use the antagonist for at least 3 days, you can still induce the surge by an agonist trigger. And this is what she showed in I think now a total of 45 patients without any OHSS actually.
And yes, you use the long-acting preparation. No, if you use the long-acting, you are stuck. You cannot, yeah.
The trigger won't be, in most of the cases, won't be enough to trigger final follicular maturation, because the LH surge will be much lower.
But she had, she showed that actually.
I saw a paper. I think that only in 2 cases she could trigger or something like this. It was in most of the cases she resulted in empty follicle syndrome, because I remember the case report that she published, and then I only saw the paper before it was published. And I remember it was I couldn't understand the logic behind this patient to try to trigger with GnRH agonists in patients that were already down-regulated after the long agonist protocol.
But the thing is, when you use...
We know that the all-day studies showed that, actually the concept behind the stop protocol, let's say in poor responders, that when you are getting to the down-regulation, so you cannot activate the hypophysis 10 days later, because the down-regulation persists for 10 days. So you are coming 3 days later and try to trigger, you are thinking what?
So if you use a depot agonist, it's a complete flat coat.
In the stop protocol, it's not.
No, I know. No, I just want to remind all of us that the reason why endogenous LH levels are higher if you give daily agonist instead of a depot is because for each injection you give daily, you will have a small flare. Even though you treated patients for 14 days, you will still be able to activate the flare.
After 10 or after 12 days, you are down-regulating the patient.
I'm not sure, bro.
Much less, but you are down-regulating the patient, and still after down-regulating the patient, if you are doing the GnRH agonist test, there is no response from the hypophysis for at least 10 days. This is the old classic studies. So to trigger 3 days later when the patient is already down-regulated, so the LH peak will be very low, and there will be no LH, no final follicular maturation. It will result in empty follicle syndrome.
So you don't retrieve. Yes. You measure LH, you see it didn't increase, so you don't retrieve.
And so what?
So give HCG, do costing, whatever. LH.
That's costing.
Yeah, exactly.
Okay.
So can I just go back to your trial? So you give decapeptyl or whatever, you give the GnRH once a day. Was this what you were saying?
Every other day from day 3 after
And
OPU.
how did you come out with every other day? What was because these were not OHSS risk patients. Why did you go for this? I mean, this is what...
No, actually we didn't know. We talked about it. We told to do it every 3 days, and we didn't find data about how long time it takes to do down regulation, and we thought after every other day will be the same, but there is no good reason to tell you why we choose this.
Also, Papa Nicolau used every other day LH in his study, not daily, every other day, 300. So
That you need twice a day LH. To speed it though.
We,
The half-life of LH is very short.
we saw that every day it will be too much and we will down-regulate the patient. And every 3 days we saw that we lose 1 day or it will not
It's got
recuperate.
excellent result, excellent data from Lutal phase
But
showing
it's
no
a different
downregulation.
model, but it's a
Yeah,
different
yeah,
model.
yeah, yeah.
We see intranasal now that the levels are much lower, and we cannot give injecting. You have much higher doses. You stimulate the hypophysis much more than with the nasal. And nasal, it's much lower. Not the pregnancy. I didn't say the pregnancy.
The corpus luteum. The corpus luteum.
I said the hypophysia, not the corpus luteum. Even the corpus luteum, the hypophysia. No.
Okay, the last case is according Shachar invitation. There is another case about poor response patient, 40 years old, antagonist protocol. She has a poor response, 4 follicles, E2 level is low, 300 to 200 picomole, and which triggering to choose, and the luteal support, and the question is about dual triggering and about luteal support with HCG for this patient, repeated doses.
Okay, I can take this one because for me it's very simple. I trigger with agonist. But what you didn't tell me, what is her baseline LH? Is this a hyper patient or what?
No, normal patient.
Yeah, okay, because I mean this is a very important message because I still receive calls from friends who say, well, agonist trigger doesn't work, and I ask for baseline LH and it's 1.3 IU or something like this, very close to hyper. I say, well, of course it doesn't work.
No.
So for this lady in my unit, agonist trigger, 4 follicles. Why agonist trigger? Because we and others repeatedly actually showed that we retrieved more mature eggs, and I want more mature eggs from 4 follicles if possible. Then when I do the luteal phase support, there's no risk of OHSS, so I'm going to give her. So the agonist trigger is not for OHSS, the agonist trigger is to have more mature eggs. Then I want to concentrate on the luteal phase support, which would be 1500 plus 1500.
Why not to give a dual trigger?
Yeah, I can tell you why.
Studies show that actually the results are or the same or better when you're using the dual trigger.
Well, whose data? Is this Shapiro with his 40 patients in each group always published in fertility?
Shapiro dealt with high responder. Leave Shapiro. But there are enough studies trying to compare HCG versus HCG and GNRH agonists. I'm not speaking about the GNRH agonist as a single arm. And when you're comparing these 2 arms, so the results are the same or in favor of the dual trigger. And there is a meta-analysis, one meta-analysis, I think it's Chinese meta-analysis, looking at 5 randomized control studies comparing both. So all the embryological parameters were comparable, but live birth rate was significantly higher when you dual trigger.
Yeah, but then again, we have to look into bias, which patients were dual triggered, what kind of the heterogeneity of the meta-analysis, etc., etc. I can just say that if you look into our studies, we don't see a reduction in the number of metaphase 2 to agonist. Yeah.
I'm speaking about
yeah.
different comparison.
Yeah.
I'm speaking about
So,
HCG to agonist and HCG.
so do I believe in agonist trigger? Yes, I do. Do I need HCG for the trigger? No. I need the HCG for luteal phase support. And this is just like this is typical US mimicking something which others got a good idea, and then we just need to do modification. I don't want the HCG here because I believe in the agonist trigger. I want the HCG there, which has been shown by all of us. That's why.
And you do repeated doses with HCG for this patient?
Yeah, I would. Yes. I would give her 1500 on the retrieval.
We still have this patient that have a problem with final follicular maturation.
That's another thing.
So, okay, so, and most of these poor responders, not most, but part of these poor responders also have problem with final follicular maturation. And in these cases, if you want to overcome this problem, so you need a dual. So why HCG in this case, to overcome the problem in this patient?
Just
Dual, double, never mind, but, so we start with dual, and then...
You know, I don't agree
that's a
with
question
you.
for you, Raul. This is patient for dual at the same time or with
Dual,
interval?
dual, not
But,
double. Double,
you know-
we're actually offering patients that either have a low number of oocytes per follicle aspirated, or patients that have more than 20% immature oocyte during aspiration. So next slide, that's what we are offering.
You know, I don't agree with you. I don't think you need a dual trigger. I have another example that I can share with you. We just analyzed our data on IVM patients, and we have IVM patients that were not previously on anything. That means pure IVM patients, and part of them we triggered with only the decapeptyl, and the other with HCG. So surprisingly, the patient triggered with decapeptyl with GnRH analog, they are more mature eggs on the day of.
I'm not surprised.
Okay, one second. And the others, okay, and the others with HCG, it took them just to do something like 1.5 days more, just to get the same.
But this is not the comparison. The comparison is not HCG versus GnRH agonist. The comparison is GnRH agonist versus GnRH agonist plus HCG. And if you're looking at Simone's study, they show that when you are activating the LH receptor with HCG, so when you're looking at the downstream cascade, so the cascade that goes to steroidogenesis are more activated. And when you are giving LH, GnRH agonist trigger, so the cascade of oocyte maturation is activated more vigorously. So actually, by giving the LH or the GnRH, you are activating more the cascade of maturation.
It's
so
not
it's
because of the LH.
Also HCG.
It's not. It's because of the FSH. FSH. It's because of the FSH.
So if you are giving also HCG, so you're not interfering. You're actually adding.
But Raul, the title of this symposium was, for me, individualized luteal phase support, and this also involves individualized trigger. Obviously, in the patient and you had repeated problems with maturity, you would do it, and Benadiva showed that in these patients, if you do a dual trigger, you get more mature eggs. The problem is that these patients don't have a higher live birth rate with these eggs. So some of these patients have a problem, which is depicted in the embryo and implantation.
I think that the two ways will be comparable, meaning to do a dual trigger and then support with HCG will be pretty much the same, like doing agonist triggering and then give two doses of HCG, which we published a few years ago. The results were very good, and again, if you maximize the progesterone during the implantation period, this is the thing. The message from this case is that everywhere you look at the literature, they say, wow, don't use HCG, luteal support, OHSS risk. However, as we all know, about at least 40% of our patients in Israel are more than 40 years of age. So OHSS is not a problem there. So you need to be practical. And a single or two injections of OHCG during the luteal phase is much easier for the patient and will induce high progesterone when you need it, versus giving them the vaginal progesterone or whatever. So individualization is the word, and don't be afraid of HCG as support during the luteal phase.
Okay, thank you very much. Thank you very much, Peter. Hope to see you soon again in Israel.